Good afternoon, everybody. Welcome to Project Echo. I'm Lindsay Zimmerman, the Viral Hepatitis Prevention Director for the Tennessee Department of Health. Although our Project Echo series is ran out of the Health Department, we do work on trying to expand treatment capacity across the state, not only with internal providers, but also external. So I do want to encourage you all that if you have colleagues or partners that are interested in learning more about hepatitis C treatment, please encourage them to join and share our information as well. So for today's discussion, we will have a presentation by Dr. Allen, our subject matter expert with Regional One Health in Memphis. He is a clinical specialty pharmacist and he has a lot of expertise when dealing with hepatitis C treatment. And then we will also have two case presentations and an opportunity for Q&A at the end, time permitting. So while folks continue to join, I do just want to encourage you that if you are interested in obtaining the continuing education credit offered through the Southeast Age Education and Training Center program, please make sure that you register. It is a separate registration than just participating in iEcho or the Echo session. So you do have to scan the QR code to set up a profile through SEAETC, and then you will participate in each session. You do have to complete the entire session in order to get credit, but then you will complete a post-session evaluation survey. The link is shared at the end, and you will receive your certificate at a later time. It's not a requirement, it's just an opportunity for you to receive that free 1 hour credit. So as always, if you do have any technical issues during today's session, please do not hesitate to private chat Kimber Miller. I believe her contact information is at the beginning of the chat, and she will be able to assist you. I see that some folks have already started adding their names and organizations in the chats. We welcome you all. Thank you for participating today. And please make sure that you include if this is your first Echo session. All right, so I'm going to go ahead and turn it over to Dr. Allen just to make sure that we have enough time as there is a lot of material to cover today. So Dr. Allen, go ahead.
All right, thanks for the introduction. Yeah, so today we're going to work through several different, I should say several, put in air quotes, several different drug interactions with hepatitis C and how to navigate them and things to consider when you're deciding a treatment regimen. Next slide. Disclosures and disclaimers, no conflicts of interest to disclose. I do want to mention here that drug interactions discussed today, it's not a full and comprehensive list. There still are other drug interactions that are not listed today. These are going to be the most common things. I also want to make note, during the submission of this, formatting was not in our favor, so there are going to be some slides that look a little wonky. It's nobody's fault. It's more of PowerPoint on different versions formatting the way they want to. So I do apologize for some of that. Was not anticipated. All right, next slide. So today's objectives, we want to make sure we can look for medications that can be problematic for hepatitis C, how to navigate that, also things that are safe and good to go, things that you want to be able to look at and feel confident going forward and not feeling like there's any issue with those medications, and also just selecting a medication that's appropriate based on medication profile as well as the other major factors that we'll discuss. Next slide. Lots of abbreviations. We've covered all of these drug interactions before, so I'm going to do more of a flyby on some of these classes, but the main indications or indicators that I want to point your attention to are the GLE-PIB, which is gabapentinoid, trade name Maverick, and then soft Vel is sofosbuvir valpatisvir, trade name Eclusa, and lead soft is ledipasvir, sofosbuvir, trade name Harvoni. That will be on every single slide, and I put the pan-genotypic options first that way because I know most providers here are going to be using those agents first, but I also want to put Harvoni is still a first line agent, so I put that guy on there as well just to be comprehensive for the first line agents. Most of these drug classes you're going to recognize, but I want to make sure I put all of the abbreviations out there just in case you're not familiar with some of them. Next slide. And then this will be kind of initial information, how to set up, how I work through patient cases dealing with drug interactions. Next slide. This is what I work through with every new patient that I see in infectious disease hepatitis C clinic. There's 4 evaluation factors that I use. The clinical information, which is anything that the patient presents to you, as well as their lab work. Drug interactions, I put it in its own unique category, especially for today. I want to look at their patient insurance and their formulary, or if they don't have insurance, going through patient assistance. And then also, if all 3 of those factors don't have a definitive winner per se, in which medication I pick, I'll kick it to the patient on whether they or which one they prefer, whether they prefer shorter course or the longer course with a 1 tablet regimen. So I leave it up to them if none of the first 3 evaluation factors lead us to one specific agent. Next slide. I always want to point back to guidelines. This is in the guidelines section. It points to making sure that you're being aware of drug interactions before you start a medication. There's going to be a list as well in the guidelines to kind of help guide you if you don't remember this presentation. You can also, the guidelines have a decent amount of interactions there to be aware of. It's color coordinated as well in its own format. So just being aware that it also references University of Liverpool Interaction Checker here. It's a free resource that is utilized, one in the guidelines and can be utilized by you as well. Next slide. And these are all the drug interaction resources that I have access to. We will, for the purposes of this presentation, I'll focus on the interaction checker information that was published in the Liverpool Interaction Checker because it is free. Lexicomp and Micrometic are subscription-based interactions. I'm able to use those as well through my employer. And so I can look and compare and contrast if there's differences between the 3 databases. So I like to use and go back and forth because inevitably there are going to be things on the Liverpool Interaction Checker that are not, it doesn't even have the drug there to even check against. And so that's when I would utilize Lexicomp. That will be the case here in this presentation. If there's medications that are not in Liverpool, I'll still have them listed here and I'll be using Lexicomp's information when that happens. Next slide. So if you've ever used Liverpool Interaction Checker, these are going to be the 4 different indicators of what type of interaction it is. Green means go. Yellow means there could be some monitoring involved. It's a weak interaction. Orange box means potential interaction. Maybe a dose adjustment may be needed. We'll put a maybe there, maybe not. And then contraindicated as the big red X means probably not recommended, or there's severe issues with it and you may want to consider other treatment. Doesn't mean it's always hard and fast, and we'll go through that with each one when we see the red X. Sometimes it's a hard and fast, sometimes it's not, and I'll make sure I try to address those things today. Next slide. So we'll have this conversation split up into prescription drugs and OTC products. That was the best way for me to skip, but I'm automatically on the very first slide. I'm going to break that rule, but I do apologize for that because these are the most important interactions that I see every single day. So I want to make sure I bundle those 2 together. Next slide. So the drug classes that I see the most as far as interactions is going to be statins, lipid-lowering agents, and acid suppressants. So I know these are going to be over-the-counter products. Some of them can be prescription, but I wanted to put them all on one slide because this is the main ones that I see in combination that are going to conflict the most. So first column is going to be trade name Maverick, second column trade name Eclusa, and third one is trade name Harvoni. So you automatically see that there's issues with statins with all of them. There's only one green box with statins, but the main thing to to remember is just because there's a bunch of orange boxes doesn't mean that everything's contraindicated and you can't use it. And we want to focus on where the contraindications with the red X's are, because those are ones where the side effect or the risk of interaction outweighs the potential benefit. And so they're not going to cause any issue with the hepatitis C drug itself. It's mainly there's going to be increased risk of concentration of the statin medication. Therefore, it's going to have an increased risk of side effects, such as the myalgias, neuropathies, or arthralgias, and rhabdomyolysis potentially. And that when they put a red X on it, it usually means those that the potential is too great and you should consider other options. So with trade name Mavorite, we see that it doesn't really like atorvastatin and it doesn't really work well with simvastatin. So that limits our options. If we see a patient on a statin, they're most likely going to be on one of those. If they're on rosuvastatin, that's great. We can still use that. The dose needs to be 10 milligrams or less. So that's why that orange box is there. The same thing is holds true with pravastatin. The dose needs to be reduced by 50%. So those are kind of the key rules with using statin medications along with trade name Mavorite. Sofosbuvir, trade name Eclusa, does work well with pretty much all statins. You're going to see the boxes there. It's going to say you should, there's a potential interaction there to increase risk of side effects. You can counsel on that, but you can proceed forward. I haven't had any issues mainly with patients complaining of side effects. So that's going to be one that I will, if I see a patient on a statin, I'm usually going to be leaning toward sofosbuvir in case there's other reasons as to why I can't. And then Lindipizor sofosbuvir, trade name Harvoni, does have an issue with rosuvastatin. It same rule applies. It has issue with potential of increased risk of the myalgias, arthralgias, and rhabdomyolysis. So we steer clear of using Harvoni in patients on Crestor or rosuvastatin. And now we want to focus on the bottom part because, as you can see, there's kind of a flip-flop of not too many statins work well with Mavorite, but then all of the acid suppressants aren't too bad in the case of trade name Mavorite. So in acids, I rarely have any issues. Liverpool Interaction Checker says the same thing. And we have to put these boxes here because this is what was documented in the research or reference article in Liverpool. There is, we'll say, a weak potential interaction there with histamine receptor blockers, aka famotidine. That's the main one on the market right now. So if you see a person on famotidine, you can probably still be confident that even if they're taking it twice daily, it's still an okay option to use in Mavorite. PPIs are the same way. There's going to be an interaction there, but if anybody who's on a omeprazole 40 or twice a day pantoprazole, I still will lean toward using Mavorite in those cases, in those patients, because on the flip side, there's much more issues and much more stipulations when you look at this sofosbuvir-based regimens of Eclusa and Harvoni. So notice how on antacids, it wants you to separate by 4 hours, either 4 hours before or 4 hours after. I don't like that. I try to just tell patients to just hold antacids if at all possible. If you feel like they're a patient that can work with the timing restrictions, be my guest. But I try to keep it simple because we're only going to be on this medication for 8 to 12 weeks. And so if we can just hold off on that medication while we're on the medicine, I'll go that route. But if we need to, I can adjust based on the patient. Famotidine, once a day at the same time or 12 hours after. Usually I just say once a day at the same time for H2 blockers. And then with the PPIs, Eclusa has the hardest restriction there. It wants you to do omeprazole 20 or less 4 hours after you take your Eclusa, and you need to take your Eclusa with food. So that has the most issue as far as counseling around it if you're going to use Eclusa along with a PPI. Harvoni is a little less restrictive as it's just omeprazole 20 at the same time. So this is just going strictly off what is in the data. So that's what I wanted to present today. A lot of information there. If you want to screenshot this or report back to this is a great slide that you may come across in the future. So yeah, lots to digest there if you haven't seen this before, but this is what I kind of work with every single day and making sure that I pick an agent that is correct as far as drug interactions, making sure it's not going to mess up the drug or mess up the patient's acid suppressant need or their cholesterol medication. Next slide. So I wanted to bundle the next two together, anticoagulants and antiarrhythmics. Lots of potential monitoring, lots of potential, not that it's going to cause an increased risk of causing harm to the hepatitis C drug itself, it's more increased risk of bleeding with all these guys. So that's why they're all marked kind of the same on the anticoagulants. That is, dabigatran has too much of a risk. It's just an increased risk of bleeding to the point of contraindication with Mavorite. Whereas, and then warfarin, you're going to make sure if you're checking INRs, you're going to want to monitor it more frequently. You may have to dose adjust accordingly during that time of on the medication. And then if you drop down to antiarrhythmics, dronedarone and amiodarone all are contraindicated with sofosbuvir, velpatasvir, and ledivosbuvir due to the increased risk of bradycardia. It even says in the when you click on it, it says serious risk of symptomatic bradycardia. So I would feel confident to steer clear of those medications if you were going to start a patient on hepatitis C medication. I would be leaning toward trade name Maverick in those patients, and I would want to make sure I do everything else that I can to make sure the drug interactions and everything else fits for Maverick's sake, just because of the severe risk of interaction with those phosphorus-based regimens. Next slide. Lots of stuff on this, lots of drug classes. I tried to be as brief but also complete as possible. So inevitably there's going to be things left out. SSRIs, SNRIs, atypical antidepressants like bupropion, mirtazapine are in that. MOIs, monoamine oxidase inhibitors, tricyclic antidepressants. The benzos, there's only just a couple. That's why I put a triangle on there. There's only just a couple. It has an issue with monitoring for increased risk of side effects with Xanax or alprazolam, and I'm trying to think of the other one, midazolam, but it's only if it's the oral syrup. So not too many there, but I did put a triangle there just because alprazolam is a very common one, so you would want to monitor for that. Stimulants, all of them are good, and I put a little asterisk there because modafinil, trade name Provigil, is the only one that has a major issue, and it's an inducer. So I would want to steer clear of modafinil in this, or try to get them to a different agent. So all the stimulants are good except for modafinil, trade name Provigil. So that would be one that I would want to switch off of, just because it has a potential for inducing metabolism. Therefore, it can cause a risk of increasing metabolism of the hepatitis C drug, therefore it not getting appropriately absorbed and not working correctly. So that's a major issue there. So that little asterisk is true that I do care, but wanted to leave that there, that most are good except that one. Antipsychotics, there can be first generation, second generation, lots of different ones in there. There's a lot of potentials just monitoring or weak interactions. There can be some dose adjustments. So I didn't want to go all into it, but there are some that to be aware of. So just look at those medications specifically if you have a patient on one of those. Migraine medications are the same way. Some of the newer agents like atogepant, trade name Qulipta, or Megapant, trade name Nurtec, and Ubrogepant, trade name Ubrelvy, those have issues as to one, you may want to consider holding those medications while you're on hepatitis C medication. Talk to them about those specific ones. So those are the newer migraine medications. Of things to be aware of, that you can have a migraine medication that has interaction with the Hep C drug. Next slide. And then this is more mental health medications, but specifically epilepsy. Now, some of these drugs on here can be used for epilepsy, but also other indications as well. So if you see a drug on here that can be used for other stuff, that's okay. I wanted to kind of group all the epileptic drugs on one slide, because as you can see, there's several CYP inducer medications here, and those are all marked out with X's. So anybody that has a strong CYP inducer, therefore increasing metabolism, therefore the Hep C drug is not sticking around as long as it should, those have severe risk of causing treatment failures or not getting the adequate drug levels, therefore they're not going to work as well. So carbamazepine, phenobarbital, phenytoin all have major issues. And then with oxcarbazepine, major issues with phosphorus-based regimens, but it is okay with Maverick. I tread lightly, but that's the agent I use. If I have a patient on oxcarbazepine, trileptal, I will use Maverick and have great success with that, even though there is a flag there at the same risk. But there's still, I have good anecdotal evidence that it does work. Just as it says, it's only monitoring, not a contraindication. Next slide. Some providers may see HIV regimens, so I want to make sure I put these out there. Most medications are, for the most part, good. There's going to be a lot of combo pills, so it'll be important to look at this slide and also look at the components of combination medications, the main thing to point out, these are kind of old drugs, but efavirenz and etravirine have issues with trade name Mavyret and Epclusa. Somehow it does not have the same issue with Harvoni. Reading through the interaction, it should, but it said it was okay on Lexicomp and Liverpool. I was kind of that was kind of a strange one to me. But the main one to note on this is that you're not it's not advised or not recommended to start glucocerebrosidase trade name Mavyret, which is a protease-based regimen, along with another protease inhibitor in their HIV regimen. It's increased risk of toxicity with the liver, increased AOT, and it's more of a you can just think of it as duplication of therapy. You don't want to start two different protease inhibitors. They're kind of going through the same pathway. So that's why you'll kind of see those increased risks. So that's one to avoid. Next slide. Then I wanted to just do a catch-all here with the last slide of prescription drugs, ethinyl estradiol. That one has a contraindication with trade name Mavyret. There's a lot of cancer medications out there. It couldn't be all inclusive. There are some that are contraindicated, some that are just monitoring. So just look at that depending on what they're on. And then this is, I think Dorinda had recommended this in the past. I want to make sure I threw that in there. As far as heart failure medications, I went through the whole list. Pretty much everything is um, looks good, but there are some to be aware of. Like Entresto, there's a risk of monitoring. Valsartan, finerenone has an increased risk of increased concentration, so it can increase their potassium levels. Jardiance has a risk of hypoglycemia. Not too concerned about that, but they're going to flag that with every single diabetic medication. So when I have diabetic medications as all green, that is the case unless we're talking about sulfonylureas or insulins. You want to make sure you're monitoring the patient more closely for hypoglycemia. So those are kind of the main things to emphasize on those specific ones. So yeah, try to be broad with that, but also cover as much as I could. All right, next slide. I want to pause here for questions. I know we're going kind of fast. I know you probably will take a minute to digest some of this. Definitely refer back to this, save it. That way you can refer back to it. And if you have questions later, you can feel free to reach out to me. You go to the next slide. I think you can go 2 slides down. Give a second for questions. Don't worry, the over-the-counter products is not as intense as that because there's lots of flags, but I tried to point out the main ones that you may see. And then I'll continue to watch the chat if I see anything pop up. All right, we can go to the next slide for introduction to over-the-counter products. We'll start out with, next slide, we can start out with allergy and antihistamine medications. There's a lot of, I tried to list everything that's most common: cetirizine, fexofenadine, diphenhydramine. Some of these are not, some of these are going to be steroids and inhalers. So, but I still want to try to put all of these on the same one. Meclizine doesn't really fall, but I wanted to slot it on here in one of these slides. Fexofenazine, aka Allegra, may increase the concentration of Allegra. So you could be see increased risk of side effects. That's the only one that had a flag. The rest of them all were safe and green, good to go. Next slide. And then cough, cold, fever. I tried to get as the most broad and encompassing of what you might see as far as over-the-counter products that people may ask you about. I do appreciate when people ask me, even if it's over-the-counter products, that means that they listen to what I said, because I always tell my patients, if you start something new, let me know. Even if it's something over the counter, if it's just for some common cold, you can just let me know and make sure it's okay, because I'd rather you check with me than not check with me. But everything for cough, cold, and flu, fever, all those things are fine. NSAIDs, guaifenesin, Sudafed, pseudoephedrine, doxylamine, dextromethorphan, all that stuff's good. I didn't have any issues as far as finding interactions with anything. Next slide. And there's some GI medications, gastrointestinal medications. Bismuth flagged on Sofbel and Ledipsivir, saying that it was a weekend acid on Liverpool, whereas Lexicon didn't say the same thing. So I did make a mark there that it said it was a weak antacid. So if you refer back to the first slide, there's going to be that issue with antacids. Lemdifisir, sofosbuvir, and sofosbuvir opazivir have all of them need acid in the stomach to get absorbed. So whenever you're going to mess with that, the pH, when you're ever going to increase that and change the pH of it, there's a potential that absorption could be um, restricted or disrupted. So that's where that flag is coming from. I didn't see the same with Lexicomp. And then loperamide, there's just an increased risk of CNS toxicity. These is usually at very high levels, probably not at just your standard dose, usually 18 or 8 milligrams or up to 16 milligrams. If you're taking that much per day, that's when you're going to see potential for CNS toxicity or QT prolongation. You would want to be aware of that. So that's the main GI medication to be aware of. And then, of course, I didn't put antacids, PPIs, and H2 blockers on here, but those would still apply. I didn't want to repeat anything on the slides. Next slide. This is the most flags with the herbal medications. And usually when I have a person on an herbal medication, I want to ask, what it's for, what they use it for, could we hold it, especially for the ones that are flagged. In the previous conversation, the ginkgo biloba and garlic, they both have potential interactions, not too much. That's why they're just weak flags. Most of these medications are not going to be listed on Liverpool Interaction Checker either. I think the last time when I presented this 2 years ago, I had my flags in the wrong place. It was on ginger and not garlic, so I do apologize that. Wanted to correct that with this presentation. That was actually garlic having a potential weak inhibition, therefore causing increased risk of concentration. Not really concerned about what it's going to do, but it did list it as a concern of potential interaction. Grapefruit juice is more of a concern just because of the inhibition there. I'm still not sure if it's going to cause any increased complications. It could increase side effects, but as far as what it can do to the drug, I don't think it's going to harm it as far as inducing it. But we will see that with St. John's wort. St. John's wort is a known inducer, and we would definitely tell the person to hold off on using St. John's wort while on this medication. Green tea has plus or minus evidence. I didn't find found evidence for Maverick in Liverpool, but then also found evidence for issues with Harboni and Epclusa and Lexicomp, and they were kind of going back and forth. And so I just marked it as flags. There's a potential for being an inducer, and so that's why I would want to counsel on that. Maybe just hold off on green tea if they even mention that. Milk thistle is plus or minus is causing an interaction. There can be some inhibitory or an induction pathways. I got different data information from different sources, and so I just made a mark there. Maybe we should just hold off on milk thistle as well while we're on the medication. Red yeast rice, it comes from simvastatin, so simvastatin flags as contraindicated with trade name Maverick, so that's why you're going to see it be contraindicated on this slide as well, just because its derivative comes from simvastatin. So if you didn't know, that's your fun fact of the day. And then we got one final slide with vitamins. Vitamins are very straightforward. The only ones that are going to flag are things that show up as an acid. So calcium carbonate, aka Tums, Rolaids, Alka-Seltzer, Maalox, anything that has that component in it, it's going to flag for sofosbuvir, opazivir, and lemdifisir sofosbuvir as an acid. It's going to be risk of causing disruption in the absorption because it's going to mess up the acidity of your stomach. Same case goes for magnesium carbonate and magnesium oxide. So if you know a person is taking magnesium supplements over the counter, you can ask them what salt form it is. They may not know that. You can ask them if they could take a picture of it or find out what it is, because there's a potential it could be magnesium oxide, and there could be an issue if they were going to be prescribed brand name Epclusa, brand name Harvoni. And everything else is fine. All the vitamins, zinc, potassium, everything's good to go. No issues with any of those. She said that the light is next slide. So yeah, this follow up for anybody who has questions in the future. Reach out to a pharmacist near you, or you can reach out to me. I want to make sure I'm available. More than happy to assist as far as how we should navigate a specific drug interaction, because like I said, some medications can be contraindicated, but we want to make sure we read the language of what it's actually is causing the contraindication, whether it be an inducer or maybe it's increased because of side effects. And maybe we just need to, if we can't change the drug, maybe we just need to proceed with caution and counsel the patient. So there's always some wiggle room. We just need to look at the patient case specifically and make the best decision for the patient. Because then ultimately, that's what we want to do. I want to make this as simple as possible for the patient to get them through the treatment course of just 8 to 12 weeks, and then they're moving on without Hep C on the back end. So, main thing is just keep them engaged, knowing that you care. Is the main thing I try to promote. Always providing my phone number on how to get in touch with me while they're on medicine to make sure I address issues immediately. And with that, I'll open it up for questions.
Hey Clark, Bill Boylan.
Yes.
The one thing I found interesting was the trileptal and Mavorite is no longer necessarily contraindicated um, due to success. Have have you had complete success, or would you say 90%, 60, 80
Yeah,
with
sure. Go ahead. Oh, still going? My bad.
no, 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 please answer.
Oh yeah. So I would say up until recently, I've probably had at least 5 or 6. So very small patient population. So this is anecdotal evidence for me. I haven't had an issue until the most recent patient. He was on triliptal oxcarbazepine. He did fail. He was on Maverick for 8 weeks. I didn't have a question about compliance because he followed up with all his appointments. He said he was compliant. But once he now that he's failed Maverick, so now I have to go to salvage treatment with phosphodieldopatazivir, valacyclovir, Vosevi. Vosevi is going to have the same interaction that trade name Epclusa does. So now I've got a bigger issue because now I've got to change that trileptal if possible. So I've reached out to his primary, or it's a yeah his psychologist, psychiatrist, whoever the provider is that's prescribing the medication to have a conversation if we can change it for the duration of the treatment. It turns out he's just going to um, modify some of his other medications to kind of increase their doses to kind of accommodate what he's using it for. And so we decreased we like weaned him off of the trileptal and then let him be stable for a couple weeks before we started the medication. So that was and come to find out, talking more with the primary care physician who prescribed it, they weren't or they were kind of suspicious about compliance because he wasn't sure if he was taking all his other medications correctly. And so then, of course, that cascaded to if the provider of questioning, did he take the Maverick correctly? Was there some missed doses? We won't know the answer to that question just based on the information that we're given. So there could be compliance concern with the patient when it's all said and done. But what we do know is that we're able to come to a meeting of the minds with his physician that was prescribing it, transitioning off of it, and then getting started on Vosevi. So that's in the last month or so that's happening. So that was a new case. Other than that case, I haven't had any issues with getting a patient cured with Maverick while concomitantly on oxcarbazepine. So yeah, great question, Bill. I haven't had any issues. So yeah, whenever I see oxcarbazepine, I automatically try to make sure everything else is catered to meet Maverick, whether it be making sure they do a PA off if it's non-formulary, still asking for it, providing evidence. I'll print off drug interactions as to why I can't use the other agents because there's contraindications, whereas there's only a slight interaction that's listed and documented with Maverick. So that's usually what I go with for those patients.
One last question with the patient
Mhm.
that did fail.
Yeah,
Was he on higher doses? Was he BID dosing at higher doses, or was he just like 150 once a day, or
of the
yeah,
oxcarbazepine, yeah, he was on it
yeah,
twice daily.
twice daily, like 300
Hmm.
higher
Yep.
dose? Okay, yeah, because and that's the one thing as you were talking through that, I was wondering if dosing had some issue. Have you were the other folk and I'm sorry for hogging this, but this
No,
is
you're fine.
me. This is I have quite a few patients that uh, occasionally are on oxycarb. Were the other ones, were they on just as high doses or typically, and I know I'm asking you to look in the rear view mirror, but was he the highest dose typically? I mean,
Yeah, I would have to go back and look because I don't know. But yeah, that's a great point that you brought up. I would have to go back and look at what their dose of oxcarbazepine was when we started, see if I can collect that because it's definitely been a year or so since the last one. But I know in the past, yeah, 7 years, it's definitely been 5 or 6 people that I've treated. I would have to go back and look at their cases and see, yeah, what dose, if I can find that information, what dose they were on, and kind of see if, yeah, he was the outlier. Like, was it because he was on BID versus everybody else was just potentially daily? Maybe that could be a piece of it too. That I'm not sure. I can get back to you though.
I appreciate it, sir.
Any other questions or comments before we move forward with case presentations?
So I'll just make a comment. I think this question about treating people who are on inducers is a really interesting space because I think that this is one of those things that we might find over time is not a major issue or problem. Um, Dr. Allen mentioned tenofovir as a HIV medicine that is used both for HIV prevention and HIV treatment, with some interaction questions about safety monitoring when patients are on ledipasvir or velpatasvir inclusive regimens. And actually, some studies showed that actually there isn't a real change in clinical outcomes in that space. And we talked about acid blockade, and we said, well, I know there's some evidence that actually shows that doesn't make a difference, but we still try to optimize regimens. This area of mood stabilizer agents, there are case series, and I'll just drop one of them into the chat. About patients who have been successfully treated on anti-epileptic regimens. What was unique in this particular case is that the people who treated the individuals put people on a medicine that would counter that induction effect. So they actually used inhibitors that would actually boost hepatitis C medicine exposure while recognizing they were on a medicine that might lower it. One of them was as simple as making sure that their HIV treatment regimen included a protease inhibitor. And so they had that in place, and so they kind of countered the other loss. But interestingly, the other two cases, the prescribers prescribed ketoconazole, an oral antifungal agent that is not one that we routinely use for antifungal as a systemic therapy. Many of you might have used ketoconazole as a topical antifungal. We don't usually use it as a oral agent because it doesn't have good distribution for systemic fungal infections. But interestingly, in this particular case, they used the medicine for that kind of off-target effect of countering metabolism. So there are different individual case reports. I suspect that we'll find more over time, but I would also echo Clark. There have definitely been times where I've had to treat through and monitor these patients, and we have had some definite successes in patients that we've had to navigate either switches or treating through.
Thank you all. Well, for the sake of time, we're going to go ahead and move forward with case presentations. If you do think of any questions, please don't hesitate to drop them in the chat.